Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the podcast. On this episode, I will talk about papillary lesions of the breast, and we'll focus the majority of the conversation on papillomas. We'll talk about different things such as central versus peripheral papillomas, solitary versus multiple papillomas, clinical presentation of papillomas, imaging appearance of papillomas, and management. In addition, we will talk about Micropapillary DCIS and papillary carcinoma. As a resident, I found it difficult to remember the nuances between central versus peripheral papilloma and solitary versus multiple, and I think this review may be helpful to clarify this. Let's talk first about central papillomas. Usually, these are solitary papillomas that are located in a dilated duct in the anterior subareolar region. A classic presentation for a central papilloma would be pathologic nipple discharge. And to review, when I mention pathologic nipple discharge, what I mean is spontaneous, clear or bloody unilateral nipple discharge. Other types of discharge, including bilateral, non-spontaneous, milky, are not thought to be pathologic, but the pathologic discharge is spontaneous, clear or bloody, unilateral. A central papilloma is the most common presentation of a papilloma. These central solitary papillomas can be evaluated with mammogram and ultrasound. And on mammogram, you would expect to see a mass and or possible single duct enlargement. Now, you may have multiple papillary lesions within a dilated duct, so a central papilloma doesn't mean specifically it must be a solitary lesion, but most commonly it will be a solitary lesion. On ultrasound, you would expect to see an intraductal mass within a dilated duct with a vascular stalk on color Doppler imaging. Often the easiest way to find these on ultrasound is to start behind the nipple, and if you see a dilated duct, follow that duct away from the nipple and look for any intraductal mass. Turn on your color Doppler imaging and look for the vascular stalk or internal vascularity, which tells you this is not inspissated secretions but a solid vascular mass, most likely to be a papilloma. You need to know about galactography, although this is rarely performed, at least from my experience, at several high-caliber breast imaging centers. On a galactogram, you cannulate a duct with a very tiny needle and you inject contrast. You have to be very careful that there are no bubbles of air in the contrast that you inject, because an air bubble can give the appearance of a filling defect, which is also what we look for a papilloma. So you need to ensure no air is injected to lower the chance of calling a filling defect from a bubble of air a potential papilloma. That is also something that is commonly asked on board exams in terms of you understanding that a filling defect could be a papilloma, but a fake out is also an air bubble that was inadvertently injected at time of galactography. I would also know that surgeons can perform ductoscopy, where they have very tiny fiber optic cameras that they can pass through the duct to look for an intraductal lesion, and surgeons can also evaluate with duct excision for diagnosis and treatment of a papilloma, as well as pathologic nipple discharge. If you are presented in a question stem with a clinical history of pathologic nipple discharge and the diagnostic mammogram and subareolar ultrasound is negative, it would be appropriate as a next step to get a breast MRI to further evaluate, given the concerning clinical finding of pathologic nipple discharge. You would be looking for any evidence of a papilloma or other mass that could represent DCIS or cancer. You also could consider sending the patient for surgical consultation, because breast surgeons are clinical experts in further evaluation and management of pathologic nipple discharge. On an MRI, you would look for a small enhancing focus or mass, possibly associated with a dilated duct, and an intraductal mass or subareolar mass would likely show washout kinetics on a question stem, because these are vascular lesions. Management of a papilloma is somewhat controversial, so they may not ask you about this, but if they do, I would not hesitate to say that it should be surgically excised, especially if the papilloma demonstrates atypia. In real life, these may or may not be excised. But on the core exam, I would always select to excise a papilloma if you are presented with that option. Many centers do routinely excise all papillomas, others do not, but for the core exam, if you are asked, just select that a papilloma should be excised. Be aware that on ultrasound, hypoechoic material within a duct that does not demonstrate internal vascularity or a feeding vessel could be a papilloma, or it could also be inspissated secretions within a duct, and sometimes biopsy is needed to differentiate these. One more point I want to drive home is a central papilloma is an anterior subareolar located lesion. On the other hand, peripheral papillomas tend to be more posterior in the breast. They are also much more likely to be multiple, okay? So peripheral P, remember that is similar to posterior P, okay? Peripheral and posterior, both P. Peripheral papilloma is much more likely to be posterior in the breast, much more likely to be multiple. And remember that these are the ones that arise from the terminal ductal lobular unit, which is really where most of the action in terms of breast cancer development is. So peripheral papillomas have a higher risk of developing breast cancer than a central papilloma. They are more likely to be posteriorly located in the breast, and they are more likely to be multiple. These peripheral papillomas do have a higher malignancy rate than the single central papilloma, and these are also more likely to be associated with atypia or malignancy. Unfortunately, these are also less likely to be detected early because these are less likely to have pathologic nipple discharge as a presentation. Okay, so that pathologic nipple discharge is really, in a lot of cases, a clinical sign that allows you to find things early. Okay, you can even detect small papillomas in early DCIS because you develop the pathologic nipple discharge. You are alerted to a clinically suspicious finding and you find the mass while it is small. On the other hand, with a peripheral papilloma, which is more likely to be cancer, these are less likely to present with pathologic nipple discharge. And I help remember that because these are very posteriorly located in the breast. So if there were any intraductal bleeding, that would have to travel a long distance in order to reach the pores of the nipple and become clinically evident. On a good note, peripheral papillomas are less common than the central papilloma. Multiple peripheral papillomas is sometimes called papillomatosis of the breast, and these are multiple papillomas in the terminal ductal lobular units. You need to know that these women are at increased risk of developing breast cancer, which I've already emphasized, and that you may see multiple masses on mammography, ultrasound, and MRI. Management of multiple peripheral papillomas is difficult because you can't necessarily excise all of these. And I have seen some cases where there are many of these, and these women often undergo many procedures. And in extreme cases, potentially mastectomy, although I do not think they would ask you about that on the core exam. On the core exam, I would select that if somebody has papillomatosis, they should have routine screening in addition to annual breast MRI. And you would biopsy or excise any papilloma that demonstrates any suspicious change over time, which can include increase in size or new development of type 3 washout kinetics. Let's round this out by talking about two other papillary lesions. The first is Micropapillary DCIS. This is an uncommon subset of DCIS that has a combination of multiple tiny papillomas and DCIS on histopathology. Micropapillary DCIS is more aggressive in terms of widespread extent, risk of microevasion, and risk of recurrence following excision. If you can remember one thing about micropapillary DCIS, it would be that it is overall a worse actor than your garden variety DCIS. Micropapillary DCIS, like other forms of DCIS, can present with pleomorphic calcifications on a mammogram, and this may also present with pathologic nipple discharge. As a reminder, if a woman presents with pathologic nipple discharge, you should get diagnostic mammogram views that include subareolar magnification views. And on those subareolar magnification views, you are looking for masses, but you are also looking for subtle intraductal calcifications that can cue you into the potential of ductal carcinoma in situ. Lastly, let's talk about papillary carcinoma. This is a rare breast cancer that typically presents as a retroareolar mass in a postmenopausal woman with circumscribed margins in many cases. This mass may have associated suspicious calcifications. If they show you a round mass on the mammogram and then you go to ultrasound and you see a complex cyst with a large mural nodule or possibly a complex cyst with thick septations, but either way, you see solid tissue and cystic components, which is the definition of a complex cyst, you should consider the possibility that this is a papillary carcinoma. Okay, cyst with nodule, papillary carcinoma. Also, to review on a prior episode on breast imaging, a complex cyst means you have solid and cystic components. A complicated cyst means a cyst that is hypoechoic but still may be completely fluid-filled. Okay, once you start seeing solid tissue components, especially if it's vascularized, that is now a complex cyst, whereas a complicated cyst just has maybe subtle shades of gray or a few minor echoes, but no solid soft tissue component. In terms of papillary carcinoma, on the ABR core exam, if they show you a cystic mass with a large mural nodule, consider that they might be asking you about papillary carcinoma. Look for internal vascularity or vascular nodules in the solid components of the cystic mass. On MRI, expect an enhancing complex cyst or cysts, if there are multiple, with irregular enhancing nodular components. Differential considerations for papillary carcinoma include invasive ductal carcinoma with necrosis. That concludes my review of papillary lesions of the breast. Go ahead and look up several images of papillary lesions, including central papillomas, peripheral papillomas, and papillary carcinoma, so you have in mind the imaging appearance of these. Key concepts that I discussed are the definition of pathologic nipple discharge, the difference between central and peripheral papillomas in terms of location in the breast and cancer risk, and the imaging appearance of papillary carcinoma. I will post a study guide on my website that is available for download at www.theradiologyreview.com. I want to thank everybody for listening. I'm pleased to announce that we have now had listeners from every major continent, with the exception of Antarctica, which is a relatively high bar to pass. Keep up the good work, keep listening, keep studying, prepare to succeed, and I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.